because we're gonna get started. So my name is Savannah and I work for WeWork, and I'm gonna tell you a little bit about what we're doing. So we are focusing on creating innovation hubs, and we're starting with blockchain. And so what that entails is basically we want to become the town hall for where the blockchain community can come and meet. So we're gathering together researchers, educators, regulators, lawyers, techies, all together to capitalize and sort of apply blockchain technology more. And what we're running is we're running a curated stream of events, which we're getting a lot of help with. And we're going to have service offerings tailored towards blockchain companies, and as well as acceleration programs that will all be happening. So if you would like to hear more about this, or you want to get involved, come find me afterwards. I'm in my WeWork shirt, so you should be able to find me. And I'm going to hand the mic over to Helen to take it away. You've already gone.
Thank you so much to Savannah. I hope this is working.
Yep.
Can everyone hear me okay? So thank you, all of you, for coming out on this rather grim night in London. I think we've had our own kind of mini NHS winter crisis with this event. And also WeWork have been very helpful to us in offering the venue when we had a venue crisis. So we've overcome a few obstacles to get here, but really pleased to have everyone here this evening. This has become sort of a pet topic for me. I spent most of my career working in think tanks and public policy and in the media, trying to explain complex topics to people in a more simple way. And one of the areas I specialise in is healthcare reform and how different healthcare systems work. And then 4 years ago I got involved in learning a bit about Bitcoin and starting to understand the applications of blockchain. And it suddenly occurred to me that there was a kind of connection between my two passions, my old passion and my new passion. So how could blockchain, with all its particular properties, be potentially useful to helping make healthcare systems more consumer focused? So this event is really a culmination of those two things, and I'm really excited to be here. We've got some amazing speakers. We're very, very lucky. We've got Pradeep Girl from Solvecare, who's also very kindly sponsored the event this evening and is responsible for our lovely drinks at the end. So thank you very much to Solvecare. But also, more importantly, for Pradeep's experience in healthcare. He's been involved for many years in healthcare IT systems and in advising several different US administrations on healthcare from all different political persuasion, so we're really grateful for his experience. We've also got a number of doctors who've actually not only been working in the NHS as medical professionals, but also got interested in the technology. So I'm sort of calling them the block docs, and it's a growing movement. We've actually got more than the ones that are in this room. Unfortunately, one of our speakers was waylaid by the snow, so Stuart Southey can't be here, but he has sent in some comments to me, which I'm going to try and incorporate into the discussion. And also, the two founders of the British Blockchain Association, which I'm a policy advisor to, are also doctors who saw that there was a need for more evidence-based policy and evaluation of blockchain projects in order to convince people in the public sector of the use of the technology. So they're not here tonight either, but I know that they're definitely here in spirit. So I'm really only going to give a quick introduction because I want to hear from the people who are really, really specialised in this area and kind of got their hands into the projects on the ground. But just to give you a quick background on Unblocked, I set up Unblocked at the end of 2016, beginning of 2017, and the idea was really to help people literally unblock this topic. So blockchain is a complex topic. It's got many different aspects. There are different types of blockchains. There's blockchain versus distributed ledgers. What does that mean? How does it link with cryptocurrencies? How are these things going to be applied? And I'm particularly interested in the applications of blockchain to different vertical sectors, including healthcare. So our events tend to focus on single issue topics, whether it's healthcare or energy, or we've got creative industries coming up. Did an event on blockchain and philanthropy last year. We also try and bring out people's stories. There's a lot of interesting innovation and entrepreneurship going on in blockchain. So we try and interview people and tell their stories in a more human way to hopefully help people get their heads around what this all means. So that's Unblocked, so I hope you'll join our mailing list to come to some of our other events in future. As I mentioned, we are very grateful to Solvecare and WeWork for having us here, and I'm going to introduce Pradeep properly in a minute. He's going to give us a quick little introduction to his experience in healthcare systems and why he thinks blockchain is going to be so transformative. But before we do that, I just wanted to talk a bit about, first of all, what blockchain is, and also why I think the healthcare system is so ripe for innovation with blockchain. So There are many different ways of describing blockchain. I mean, in a way it's quite boring. It's a sort of massive shared secure database that keeps a chronological list of all the transactions going on a network, and that sounds quite dull. But because of those properties, it allows us to do many different things, and that's why it's becoming interesting in areas like healthcare. If you've got a system like the NHS, it's really not one monolithic system. It's a whole combination of different mini institutions joined under a brand, if you like. So you've got GP services, which are kind of family businesses. You've got hospitals, which probably haven't really seen any kind of systematic innovation. They've seen medical innovation, but they haven't seen any real system innovation for a long time. You've got all the different administrative and financial parts of the system, and it's very hard to connect those up and to actually get people's interests aligned. And this technology gives us one way of potentially doing that. So why is that useful? We may be able to help patients use their own data more effectively and access their own healthcare data. We'll hopefully be able to help medical professionals to share healthcare outcomes data more effectively, which is a very difficult thing to do when data is in silos. And there's huge volumes of data coming into the system from all different sources, whether it's wearables or genomics data, other kinds of data that are coming in that we just can't manage to deal with. We've got huge amounts of admin costs and bureaucracy in healthcare systems, not just in the NHS, but these systems operate in a very kind of dysfunctional and suboptimal way. Maybe blockchain can help with that. We'll hear from some of our speakers about that. We're also in this period of austerity measures, which means governments ultimately are looking to save money on how they run their welfare systems. And that's been tried many times. We've had sort of litanies of failure in terms of healthcare IT system reform. But there's still, I think, a possibility for blockchain to come in and make enormous cost savings in the way we do a lot of different processes. And that could be very important as we get into a stage where we've got an aging population, we've got rising pressures on the healthcare system. We've also got issues of just simple failures all the time. Your test results go missing, they take a long time to get to your doctor then takes a long time to get them to you. I mean, this happened to me actually when I was pregnant with my first child. I was suspected to have gestational diabetes, and by the time the test results from the test had got to me, I'd already had the baby. So, the system doesn't work in the most fantastic fashion when it comes to timing. So that's something else that we can potentially speed up. And then we've got the opportunity for whole new business models, which we haven't even talked about yet. We're sort of talking about this perhaps rather grandiose topic of can blockchain save the NHS, but there's also the possibility for lots of different new healthcare business models and innovations with blockchain. So I'm just going to leave it with those kind of questions hanging in the air for now, and what I want to do is hand you over to Pradeep. Pradeep's, I've already heard him speak in public several times. He's a fantastic speaker. He's the CEO and founder of Solvecare Foundation. They're doing great work. They've just got some big announcements out today, which some of you might have already seen, but I'll let Pradeep talk to you about those, and also talk to you more broadly about how, if we bring decision-making more into the hands of the patients and people running the system, we may have a better way of doing healthcare. So Pradeep, over to you.
Good evening, everyone, and thank you, Helen, for organizing this event on a particularly challenging weather day, and thank you, everyone, for showing up. And I want to thank the lovely volunteers, I don't know where they are now, for coming and helping us. We just lost them. I think they were just here recently. But thanks for that. There's a lot to be said about healthcare, and we can talk for hours, days, years, obviously. But I want to talk about three things today, which I think will be relevant to those who are looking at blockchain and improving access to care or quality of care, and NHS is the focus. My experience is in the US. I haven't worked in the United Kingdom, but there is actually a very similar program as the NHS in the US, and that's called the VA, the Veterans Administration. And it literally is a copy of NHS. You have regional hospitals who have captive audiences, and you can only go get care in these hospitals because you are a veteran. And you have the same issues of access, quality measurement, payment, delay in care, and so on. They're literally copies. So I'm going to use that as an example to show you how blockchain could work in a government setting. Because clearly there are questions. Will government ever adopt the blockchain? What are the barriers to adoption? So before we jump into that example, and I set the context and give you a little background. I've been in healthcare IT all my life, stumbled into healthcare and then never really left. I've had the opportunity of working on the commercial insurance side as a CIO of a major Blue Cross. I've had the opportunity of working with the federal government in implementing large systems for the federal government in the Medicare program, which is for the elderly, the Medicaid, which is for the poor, and the VA, which is for the veterans and the war heroes that go to fight for America, presumably. Those are the programs that are very large, equivalent or larger in size than the NHS, and they suffer from the same set of issues. So let's talk about let's first talk about the government's intention, and those are similar. And I've been on the buying side of the government as well as the sell side, meaning I've sold to government and I've bought as government from vendors. So when people come to the government and say, I have this brilliant technology, I would like you to adopt it, it doesn't move the needle. It doesn't get me to act at all. What I'm looking for is the answer to 3 questions. First, is this technology going to do any harm? Because nobody in government gets fired for not doing anything, but you definitely get fired for breaking something. So you want to make sure that whatever you do is a net positive or do nothing. So you have to demonstrate to me this is a net positive. Do no harm is the first rule of government. The second is, does it increase my risk? I may be pro-innovation, but I'm much more anti-risk at all times. So my number one concern is your solution going to amplify risk for me or any of the stakeholders? If I perceive the solution to increase the risk for the patient, or for the physician, or for me, or for the treasury, I'm not interested. So your solution must be presented to me as don't increase the risk. Because if it does, everything else becomes immaterial, right? And that's true in the US, that's true in UK, that's true in Australia, that's true in the Middle East. Government behaves very similarly. And I can speak from experience having worked with all these governments. The next thing that I look for is what's the ROI? What's the window of ROI? Will this be in my tenure? I'm appointed by the president, I have 3 years left. Will I be able to demonstrate ROI in that window? If you're outside my window, I'm not interested. Because then somebody else will take the credit for me doing something and risking my job, and I don't even get to see the benefits. So your ROI must fit my tenure, whatever that is. If you're a 1-year appointee or a 4-year appointee, will determine how big a risk I'm willing to take. Those are always the factors. When you close the door after the vendor has done their pitch and they have left and they're feeling really good about the use case, and you sit down with your team as a government buyer and you ask the question, should we buy this? Those are always the questions. Will this increase my risk? Will it do any harm? And will it be successful in short enough window for me to demonstrate and claim victory? So when we are out there selling blockchain solutions, whether it's in Dubai or in Abu Dhabi or Singapore or UK, Australia, Belgium, France, we've been around the world in the last 3 months talking to governments around the world. Those are always the concerns. So now let's bring that back to blockchain. What does it mean? Blockchain represents a tremendous potential. We can all agree upon the fact that if applied properly, this can put the system upside down. And in the very fundamental way, this is my personal belief, that we can use blockchain to delegate more authority to the patient and more authority to the doctor without losing control over key parameters, such as cost, utilization, and quality. If you can do that, then what's the harm? Why wouldn't I want to give more power to the patient to see whichever doctor they want to see? Why wouldn't I want to give more power to the physician to see the patient more quickly, get paid faster, thereby improving quality of care, reducing morbidity levels, and people getting out of the hospital faster? That's my mission, whether I'm NHS or VA. That is my goal. But I would do that only if it does not amplify my risk, if it does not amplify the risk to the patient or the doctor. So having said that, I'm going to bring you back to the VA example, and hopefully that'll map to the NHS. In the VA, we have a fundamental issue. Every hospital has a fixed supply of physicians, fixed supply of beds, fixed supply of radiology hours, and so on and so forth. But our demand is very unpredictable, and it depends upon what happens in the far east. Some major event happens, and we get flooded with a huge amount of demand. And then there can be 3 months of lull, and then you suddenly get another incident, and you could end up with a huge imbalance in demand and supply. So there is a real problem with always managing care when it's needed Either we have too much supply or we have too little supply of physicians, ophthalmologists, and all the specialties that go with it. We can staff to general practice, but we can never staff to specialist care. So what do? We basically tell people to wait, we triage, we tell them, well, you are not as serious as somebody else. Well, the person's sick, that doesn't sound like a fair deal. I'm suffering, but somebody else gets to be treated before me. But that's the way it plays out, because a demand-supply imbalance, always. Either excessive supply or excessive demand. So the idea of blockchain that the VA is exploring is very interesting. Their idea is that whenever there's a demand-supply imbalance, we will delegate more authority to the patient to go outside the system for a specific purpose, for a specific duration, and let them choose the most available, the most qualified physician for that need, and still have continuity of care when they come back into the system. Because you really don't want them to leave the system permanently. You want them to go get care and then come back so we can continue the rest of the care, right? Because specialist care is not an isolated event, it's part of a care continuum. So you want to give them power to go out of the system, but return back. And in that sense, blockchain represents the opportunity for a physician who the VA has zero relationship with, does not know them, to be able to treat your patient for the episode that you want them to be able to treat the patient for. And that's where the chain starts to get very attractive. Because now you can actually have a physician sign a dynamic contract with the VA for maybe a single patient, treat them, get paid, and maybe never treat a patient again, but we got the demand-supply balance done. See, it's the opposite of integration. Today, for that to happen, I would have to go sign a contract with that physician. It's a 3 to 6 month process. By the time patient is long dead or doesn't need to be treated. So the idea that I already know every physician in the system is what is called a constrained supply. But if I can have dynamic supply, if I can allow physicians to come into the network truly on a case-by-case basis and leave the system when they don't want to or they don't need to be, we have what is called dynamic contracting. Now that's a dream of the VA administrator and even the occupant of the White House. This is what we are trying to do. We're trying to change demand-supply by breaking down network barriers. You can apply the same model to the NHS. You can talk about delegated authority to the patient based on a specific case in the form of a token that they can take to any physician who also has an equivalent token proving their credentials. So we know that's a real physician with the real credentials to treat this particular scenario, and exchange those two tokens and guarantee payment. And they may exchange that token once or 1,000,000 times, depending on how much need there is, but there is no need for a permanent contracted relationship between the payer, the VA, and the doctor, who may practice primarily in a private practice. When we modeled that scenario, we realized that a typical specialty care, which takes about 9-month wait on average, it's a stunning number, 9-month wait from referral to actually seeing the specialist, down to about 9 days. Because there is actually a supply of physicians who will agree to a dynamic rate contract if they don't have to go through the immense paperwork and the pre-certification and the integration of data and the EMR and all those things. It's purely a transaction. I have availability on Thursday at 3 p.m. I happen to be free. You happen to want to need my services, and the VA is committing to pay me real time. Why wouldn't I fill my supply imbalance with your demand needs? So those are the type of use cases that are being explored in the US that I think will start to percolate outside the country, outside our continent. I want to talk a little bit about similar dialogue we had in Dubai with the Dubai Health Authority. We are talking to governments in France and in Belgium. And what we keep hearing is, I am interested in blockchain if it helps me accomplish one or all of these three things. I want to show my citizens or my population that I am responsible for that you have more flexibility in choosing your physician. I want to be able to show the physician I'm going to pay you real time or close to real time, and I want to pay you accurately for the service you delivered. And then I want to be able to show my bosses, whoever is funding me, that I'm paying the right amount for the right reasons. So the care access, care quality, care cost. If you can address one or more of these use cases in blockchain, they're wide open to the idea. As long as we can answer the three questions, this doesn't increase risk, It does have a short-term enough window for implementation. It's not a 3-year journey, it's an 18-month, a year journey. And we can demonstrate to you that this is not going to have one party be disadvantaged at the expense of, at the advantage of the other. This has to be a win-win model. But it's interesting to note that when we explain the blockchain's value proposition in those terms, there has been almost no resistance to, let's try it. How can we not try it? So the issue isn't what we expected. The government is resistant to change, they won't do it. It's more the question of, if you say what you can do, then we are all in. And that's what we're seeing in the market. So that portends to a very optimistic outcome here as well. If we can deliver very clear use cases with those criteria, then I think NHS is as ready as any other entity. Now, I speak only from an extrapolation of what we are hearing in other governments. I have not talked to the NHS myself, but what I am seeing is a very willing and readiness to improving access to care, reducing the cost of care or fraud or waste or overutilization of care, and improving their timeliness of payment. So those are the use cases that we see getting traction around the world. Final comment I want to make is that it is clear blockchain is early. We are in the infantile stages of any technology curve. Blockchain isn't mature yet. So it is important to recognize that we are going to see a rapid evolution of technology, hopefully driven by the use cases. So things like identity of the patient, security of information, ease of usage, scalability, performance, and most importantly, who is the person responsible when things don't work? The idea of decentralization is scary because it implies that there is nobody who's responsible when things go to hell in a handbasket. And they will. Technology always fails at some point or the other. Who is the support authority? Who do you go to say, hey, it's not working, fix it? And that, I think, is some of the key impediments of blockchain technology adoption. Not the technology itself, but the support structure behind the technology. Who is going to support the government agency when things aren't working? Because they're not going to support themselves. They need you to create a forum. And then last comment I will make, and then I'll turn it back to Helen. One of the things that we have heard is a lot of companies are in the shop of the government pitching solutions. Hey, look at my blockchain, look at my blockchain, look at IBM's got Hyperledger, Ethereum's got there, and there are many coming every day. And what we are hearing more and more from the government buyers is, I don't want to buy from individuals, I want to buy from a consortia of some sort. You find out which digital ID and which blockchain and which electronic medical record and which app comes together. I want a solution. Right now, all they're hearing is pieces. Here is my engine, here's my transmission, they want to buy a car. They don't want to buy pieces. So I think many of you, and I don't know your backgrounds, but if you are in the blockchain for healthcare business, understand that this is the time to collaborate and go to NHS or VA or Medicare or Medicaid or the Ministry of Health in Dubai and say to them, here is a consortium of 6 companies or 10 companies that have agreed to build a solution that meets your entire end-to-end process need. Because they're going to buy process simplification, not a piece of technology. Nobody really goes to the car showroom and buys a 4-liter combustion engine and then goes off and shops for a transmission and hopes that somebody will assemble it for them. So blockchain is in that stage right now. And I would urge here, and I say the same thing in the US, the time for competition will come. Right now it's a time for co-opetition. We need to get people to come together and build solutions. And if we do that, I think you'll find that government is ready in more ways than one to adopt the technology. I'm happy to take any questions. I'll be here for a little bit longer, so please stop by. Otherwise, thank you for coming. I appreciate your time.
Thank you, Pradeep. Just before you go, I just wanted to ask, you've looked at lots of different healthcare systems around the world. Do you think that blockchain has more potential in any one type of system? I mean, obviously the NHS, we have this tax-funded, top-down system, if you like. Other countries like the US have an insurance-based system. And then in other parts of Europe, you've got a more hybrid mix between public and private. Do you think that blockchain is sort of system agnostic, or do you think it has more potential in one type of healthcare system than another?
So I think it really doesn't matter. When I put on my CIO hat of a Blue Cross, I would look at the same cases. In the end, I am writing the check for healthcare. I want the healthcare to be delivered efficiently and timely, and I want the results to be as optimal as possible, right? And I want to make sure my physicians are delivering the best care they can without being administratively overburdened. So whether you are a commercial insurance company writing the check, or you are an employer, self-insured, writing the check, or you are a government agency writing the check, the common theme is I'm writing a check and I want to see it done better. So in that regard, it's the same. What changes is really the flows, right? Who is writing the check when is really the only question. So when you look at value-based care versus fee-for-service, I pay in fee-for-service I pay first, and then I hope you did a good job as a physician. In value-based care, I don't pay till I'm sure you've done a good job. Regardless, right? It's simply a flow process. So I don't think it's going to matter so much which sector you go after, commercial insurance, employer-sponsored healthcare, or government-subsidized healthcare. What will matter is, can you demonstrate a use case that speaks to either access to care, quality of care, or cost of care.
I mean, it's interesting that in different systems you actually have very similar problems, regardless of how it's paid for. From the patient's perspective, you still have the delays, the admin, you know, the reconciliation process. If you're talking about insurance, you have all these problems. So actually, from the patient's point of view, similar problems exist regardless of the.
Absolutely. I think that the patient experience is still very fragmented. Like you spoke of your personal experience, my personal experience is the same. And I think you heard me say this, you know, my 3-year-old needs a lot of care, and I can call up the CEO of every insurance company or hospital, but when it comes to coordinating his care, it's an absolute nightmare. It's absolutely ridiculously complicated. And even though I'm the one who wrote the systems to generate those bills that we get, I don't understand those bills that we get. And I don't understand why it takes 7 months for a neurologist to see him. But it does. So I don't think that it matters very much what economic strata you're in, what program you're in. Ultimately, the patient is disempowered and largely a recipient of care. And I think if we can use at least some use cases in blockchain to delegate more authority to the patient, we're going to see a more engaged patient, a better physician experience, because physicians also have to struggle with patients' disengagement. And then you have ultimately a better healthcare model. So I think we will see that. But it's a journey. We're not going to get there tomorrow.
Okay, before we go to the panel, we're just going to have a couple of questions for Pradeep. I'd love to get a show of hands first about people in the audience, whether you consider yourself to be, first of all, knowledgeable about medical or healthcare systems. So quite a few, maybe about a third, I think. Obviously not the speakers, who we hope will all be knowledgeable on both sides. And then how many people feel they're knowledgeable about blockchain or distributed ledgers?
You got to put your hand up.
Okay, so probably about a third of each. And any people who feel they're knowledgeable on both? Okay, so a much smaller subset. So, yes, I think a man at the back, you had a question there.
I was thinking about how do you use a token, for instance, for patients? Do you have like a reward system? I listened to one company a couple of weeks ago, they use token to reward a patient. For instance, they can sell their information to medical companies.
So it's a question about how you use a token in the system, and is it a reward mechanism? So can the patient sell their data, for example?
There are many use cases, and certainly sovereign patient owning their data, selling it to those who will reward them or compensate them appropriately is certainly a often used use case. The model that we are exploring in the VA, for instance, isn't patient ownership of data. We're focused on giving the patient the authority to go see a doctor outside the system. So the token that is issued into the patient's care wallet is really an authorization token which says, if you, Mr. Physician, agree to see Pradeep because he needs an ophthalmology exam for a retinal exam or something along those lines, and you have the qualification to do it, then if you accept that token in lieu of seeing me, you are guaranteed A, payment, and B, a fair calculation of the amount. So the objective of giving you the token is essentially a voucher, right? But we could issue you a paper voucher and you would accept it. But that's not really enough. The voucher has to calculate the fair value of your services at the point you deliver it. So it has to be intelligent. And the value of blockchain there then becomes that when you accept the token and you code it with your procedure code, ICD-9, ICD-11 code, whatever the mechanism you want to use, at that point in time, we can tell you instantly, hey, this is the amount of money you will receive. Now, you may take that token, once it has been assigned a value, and either redeem it with a VA, or preserve it, or trade it, give it to somebody else. And now they have inherited that value. So in effect, you have this flexible currency that calculates the value of the service you delivered. And the service you give it to Helen the next hour may be vastly different than me, and the same token will change value, right? So the idea is the portability of access to care, the right to use care without me losing control over the cost of care. So I'm delegating power to spend the money, but I still control the cost of services. Does that make sense?
Well, I guess that raises an important question, is a lot of people would say, what's cryptocurrency got to do with healthcare? They would assume that cryptocurrency means Bitcoin, it means people wanting to speculate and make money out of a currency that goes, quite volatile up and down, or they might think, this is something that people use on the dark web. They wouldn't necessarily associate cryptocurrency with healthcare, and obviously we're talking about difference between a token, if you like, and a cryptocurrency, and used as a currency as opposed to being used within a network. So maybe you could just talk quickly about the difference, and also about whether patients should know that they're using a kind of a token. How are they going to be educated on how this works? Because that's very confusing for people, I think, to understand.
So from a payer perspective, you don't want to issue a volatile currency. No doctor will accept a payment that will change in dramatically the value the next morning. They need to run a business and pay their staff and pay the rent and be in business. So the idea of, but you can have variable value currency, just not fluctuating on its own. So variable value currency is very powerful in healthcare. If I go to see a doctor and the base flat rate for an office visit is $35, my token needs to have a base value of $35. It needs to give the doctor that much money. But if you want to incentivize a physician based on value-based care, outcome-based model, and we want to give them an incentive to do certain things, and if 30 days hence those things show the right results, I want to increase the value of the token to $45. That's called value-based payment, or performance-based payment, or value-based contract. The idea is very simple. You reward the physician for doing the best they can do, complying with best practices, following up with the patient, ensuring that the patient is doing what they can do, so being partner in the recovery of the patient, not just deliver the service. Then that value-based contract will have variable value. So $35 will not become 30, but $35 could become 50 based on events. And that allows you to implement the most difficult part of healthcare payment, which is value-based. Because you want to give both the patient and the provider the tools to do the best they can to get well. And that's value-based care. And value-based care is hard to measure and even harder to pay. So a token makes it very simple. So it is variable value, but not fluctuating like Bitcoin. It's not going to go from 30 to 300. It will compute a higher value based on the results. And if the results are poor, you could also theoretically decrease the value. But typically you would not do that. You would still pay the physician the rate you want to pay them as what's called the rack rate, or the base rate, or the service rate. But you want to give them incentives. So it is a combination of base fee plus rewards. And we are actually implementing precisely that model right now for one of the largest hospital chains in the US, which has hospitals in 17 United States states. And that's the model they want to do. They want to pay their physicians, thousands of them, with an electronic currency that they will issue. It's their own coin, but that coin has a fixed value and a variable value component. Now they can mix base monthly rate or base salary plus performance-based model on top of it. So that's an example of a currency actually working, but you won't want that currency to be wildly fluctuating. So it has to be a stable value and a guaranteed value.
And maybe the patient never really actually knows that they're using blockchain or using a token, if you like. It's described in a different way.
Yeah, I don't think that I would want my mom to try to figure out the blockchain is driving her care wallet. I think she just needs to know that she can take the care wallet, see the physician she needs to see, and when she transfers, I've received care button on her app, she's done. It's the physician who recognizes the accumulated value they have received. But we don't want to explain to people how the cars run either. We want them to drive it.
One more question, then we're going to move to our panel.
So I work in value-based health. So we look at best models,
Yep.
look at the individual, and then look at the most cost-effective treatment.
Mm-hmm.
How would that benefit what you're trying to do? Because we're already executing with the insurers. So how do we help the physician understand that model?
Yeah, it's a great question. So again, there are two sides of value-based care. One is physicians' behavior, compliance, if you will, with the best care practices. And that's in itself a difficult model, because physicians are physicians for a reason. They have accumulated different experiences, and they will operate based on experience plus care protocol, right? The care pathways or best practices, as you would like to say. So the idea is that we need to measure compliance in multiple ways. First is whether did the result meet our expectations? Did the patient get out of the hospital within the expected window? Did this overstay by a week? Did we get them out 3 days earlier? So in the US, we use hospital stay as a key indicator of quality. Then there are clinical indicators, A1C measurement for diabetics. Are they going up or are they going down? Refill rates, are they taking prescription full course or are they dropping it in the middle? There are many patient-centric variables, right? And then there's finally the cost variable. Did this total cost process, the care journey as we call it, how much did it cost us? Is it really in line with a standard care journey? If I expect a certain episode, a standard type of episode, to cost me $100,000, cost me $1 million, why is that? Is that justified? So with those three measures, some of them will come from the clinical evaluation, some of them will come from administrative costs, and some will come from financial. The objective is to be able to compute in real time the accretive value of the token, and also to show the physician how much more they can earn if they do something like submit a care summary document, and so on. So it's both a tool to pay them, also a tool for the physician to understand they are leaving money on the table. They can earn more. And that's what we hope will change provider behavior.
Okay, well, talking of physicians, we're going to ask our three blockchain doctors to come up to the stage, if they would, and join me on the panel. So we have with us Dr. Abdullah Al-Bayati from Medical Chain. We have Dr. Navin Ramachandran from IOTA Foundation. And we also have Dr. James Somaru, who works with a number of different healthcare startups. He's part of an NHS accelerator and is also launching his own HS Live. So what I'm actually going to do is ask Pradeep, do you want to join as well?
Okay.
Maybe to that end. We're going to ask each of them quickly just to introduce themselves and explain the answer to this kind of slightly puzzling question. Why would a trained medical doctor, get interested in blockchain? So Abdullah, maybe you can kick off for us.
So good evening, everybody, and thank you, Helen and her team, for inviting us here today. So my name's Abdullah Al-Bayati. I'm a practicing doctor. I'm still practicing. I actually have a clinic tomorrow morning in Leeds, so I hope the snow won't stop me from going back.
We're praying for the trains.
Yeah.
Otherwise, he's coming to my house.
Yeah, it's a very generous offer. Yeah, I mean, essentially, I think for all of us here, not just from a clinician perspective, but somebody else involved in healthcare from another aspect, is because you see a broken system. And for us working in the UK or working within the NHS, we're proud of the NHS, we love the NHS. I think it's a better healthcare system than most of the world, but in one way or another, they all have issues and they are all archaic in their own ways. And when we stumbled across, I'm sure all of us in one way or another came across blockchain for the first time and thought this is some kind of magic technology that's all of a sudden been invented, and our brains started whizzing around, well, how could I use this? What could I do with this? And then the idea is, so from my background, I'm the CEO and co-founder of a company called Medical Chain. So we're a company which is there to develop a platform for the utilization and storage of electronic health records using blockchain technology. And we've essentially put together our platform now where we're able to do this, and we will have a pilot running in the NHS in June, July time, where the patients will be able to go away with their records on their mobile device or their web browser, and they can interact with doctors anywhere in the world by showing them their medical records, which will always be kept live and up to date. And will also facilitate, for example, a telemedicine application. So the idea, I mean, when I've worked in A&E is full of patients, for example. Like myself, I'm a patient also, and I queue there for 3 hours to find out I had a sprained ankle. Or the rash on this child was a very simple rash. And it's just an inefficient system. If we could use a telemedicine application where you can see the rash on the child, the doctor can allay the parents' fears, give them that quick bit of advice, and that's what most of medicine is. You just want that quick bit of advice. If you actually think you've got bowel cancer, you will want to go and physically see your doctor and talk about that in depth. But that's very rare in somebody's lifetime to have that episode. The majority of healthcare problems are advice. I'm talking from my position as a GP now. I'd say 90% of my patients go away without a prescription. 90% of my patients go away with advice. 90% of my patients are told to come back and see me in a month and we'll talk about it. So I think using blockchain technology came across to me as this is a way to solve this kind of pain point we have.
Yeah, we'll come back to the patient point of view in a minute because I think it's really fascinating and important. Navin, up to you next to talk a bit about IOTA and a bit about maybe medical data for professionals as well.
All right, I'll leave the IOTA bit for later. So I've been in blockchain for ages. for like over 10 years. And I let that sink in because whenever you hear anyone say that, they're talking rubbish, because the Bitcoin paper came out at the end of 2008. So this is why I kind of got into this, because a lot of stuff that's said when we're talking about blockchain is rubbish. So we're in a speculative market, and the majority of us got interested in this because the price went up. And that's why it's caught the public imagination. And people have lost sight of why the ledger came out. And that's what I want to try and bring back. What was the point of the ledger? So what do? I'm an interventional radiologist at UCLH. That's my full-time job, and I do this in my spare time. And at the end of 2016, I joined the IOTA Foundation. The reason I got interested in blockchain was initially because I was looking at data integrity and how do you make sure that data that you're reading is what it says it is. So how does that fit in with a blockchain paradigm? So the blockchain came about because we wanted to take control away from central powers. So initially the banks that controlled how money was spent around. I think the economy has changed to an extent where it's not the people who necessarily control the money, but the people who control the data that decide what happens. So can we use that same blockchain technology to also take the control away from the central powers and put it back to the citizens, the patients, whatever you want to call them? So I joined the Center for Blockchain Technologies at UCL about early 2017. And since that point, we've been looking at how we use it within healthcare and outside. And the things I want to touch on later on is, even though we chuck around blockchain technology as being the future, what does it actually mean? Can we actually scale it? So right now, most of these systems are running at 7 transactions a second in the world. It's like, if you can run the world on that, you're doing well. The way to get around that, people say, okay, I'll build a private ledger. Because, you know, these private blockchains are awesome because they tend to be much quicker. But the point of the blockchain was that they weren't supposed to be centralized. And once you build a private ledger, you get rid of that. And it gets rid of the speed, but also the fact, the other thing that's used in this situation is saying, look, healthcare data is very private, and it should never end up on a public ledger. Well, only an idiot would put your actual data on the ledger, and no one would ever do that. The point of the ledger is consensus, to decide that something happened. And I'll trot out this analogy that I put out. It's the same as watching a getaway car from a bank robbery. So if you have a blacked out getaway car leaving the site of a bank robbery, you can ask any random stranger around there, and a group of them will give you a consensus that a blacked out car with this license plate went past. Because it was blacked out, they won't know what was inside or who was inside, but they can still tell you that car went past. And that's my analogy for a public blockchain. You don't need to know what the data is, but you need to know that that data was stored there, and once you unwrap or unblack out the blinds or the windows, you can see what was inside. So that's what I want to take it back to, away from the speculation and the hype.
I'm going to turn to James next. I mean, I think you've raised an important point about the history there, which is, the original innovation of Bitcoin, which is the original blockchain, was to be able to do peer-to-peer transactions, payments without any need for a third party. Then we moved into sort of next wave of understanding that we could apply that technology to other processes and introduce smart contracts and sort of program the system to do certain activities according to certain conditions being met. And now we're moving into, I guess, the kind of third and fourth wave, which is, first of all, the rise of ICOs and token sales and using these tokens in different ways, but also different types of blockchains, whether we're talking about public blockchains like Bitcoin, whether we're talking about private permission, sort of intranet type blockchains or consortia blockchains or next generation protocols. We've got a lot of different innovation going on. So the topic gets more complex, but it also potentially allows us to do more things, and maybe those systems will also work together eventually in the future, but we're still at this quite early stage of trying to understand what we can and can't do. So that brings me quite neatly to James, because James actually works with technology companies and he tries to get this stuff done within the NHS. So James, I know you trained as a doctor, but now you spend more time dealing with entrepreneurs and innovators.
Yeah, hi everybody. So my name's James. I'm an anaesthetics and intensive care doctor by background, so I was clinical for 5 years. I then had various roles in sort of leadership and policy, and for the last 18 months I've run an accelerator for market access to the NHS called the Digital Health London Accelerator. I'm now one of the founding partners at HS, which is an accelerator which builds and scales healthcare companies. And yeah, I guess from my perspective on this, you know, I'm not a blockchain expert by any means, but I drive innovations in on the ground floor and I get things done. And for me, I would flip this conversation around because I think a lot of this hype around blockchain is all trying to fit the solution now into problems. And what I do is really work with the NHS side to understand what the problems is, and that would be my kind of challenge for everybody that is interested in doing things in blockchain is now, can we see some really good demonstrator cases of problems being solved, and can we start combating some of these issues around, you know, it's a huge system, the NHS. Well, first of all, there is no such thing as the NHS. It's thousands of independent organisations that can do what they like, and there's issues around scale and things. So can blockchain go in and solve these small problems very well, which I know, one of the panel certainly is starting to do now. And that's my interest, is flipping it around to actually solving real problems.
Thanks, James. So I guess I'm going to follow up with you and say, I mentioned at the beginning the history of commissioning IT projects in the NHS is sort of not the most glorious CV, if you like. So will blockchain be any different, or is it just going to be something else that people look at and say, why did someone come up with the idea of the NHS spine? Why did they come up with the idea of the NHS blockchain system, which was such a colossal, expensive failure? And that's, being pessimistic, though, I love this technology, but I think some people might argue this is just going to be another IT system. What's different about blockchain compared to any other
I think
IT solution?
Yeah, no, absolutely. And I think that's up to the innovators to show everybody else. And I think that starts with solving small problems very well. It's going into a GP practice and solving a problem for GPs and scaling out of there. I don't think you're going to see the day, although I might be wrong, where blockchain is all of a sudden rolled out NHS-wide like the spine or like anything else that might not have gone so well. I don't think that's the way this is going to happen. I think what we need to do is really get in and understand what problems need solving, because ultimately it doesn't become about the technology, it doesn't become about what's under the hood, it just becomes about the fact that a patient might be able to unlock certain things for their clinician by tapping something on their wrist or whatever it is. That's what it's about. It's not. It might be blockchain under the hood, it might be something else completely different, but ultimately if it goes in and solves problems, then absolutely ideal. And I like what was mentioned earlier about, not just solving a bit of a problem, really kind of collaborating and understanding, what it takes to actually solve an entire problem end to end. A hospital and a GP practice and a CCG and all these different elements of healthcare. There are so many moving parts, there are so many budget boundaries, there are so many issues to solve that cross different people, different stakeholders. And whilst if you do solve a bit of a problem, okay, great, but actually if you're going into a budget holder and saying, well, actually, look, I can cut this budget by this much in this way and actually solve a problem end to end for somebody, it becomes a lot easier to get bought, procured and used, essentially. But it starts with really understanding the problem that you are solving, not trying to crowbar in a solution called blockchain because there's loads of hype around it. It starts with understanding what actually is the problem around identity that needs solving. What is that? And what does that look like? What does that look like for the people that feel the problem on the ground floor? And what does that look like and feel like for the people that are then going to buy something? Because ultimately, with anything, particularly in healthcare, but any business, what problem do you solve? Whose problem is it? And are they going to pay for it? If you can answer those questions with your blockchain solution, great, then we're on the way to something.
And do you think that small startups have a chance to get their foot in the door? Because obviously there's something like this that's so huge and transformative, there's a chance that it could just be the large enterprise that comes in and gets those government contracts. So what could or should startups be doing to kind of get those bottom-up pilots going?
Absolutely, and I'm sure you can ask the startup on the panel who's
I'm going to ask him that in a minute as well.
The smaller startups have that ability. The rise of the doctorpreneur is useful. These doctors that have this interest in blockchain, they also have very good relationships with people on the ground floor that feel these problems. There's a huge kind of chicken and egg in the system between getting a trial and getting evidence. because in order to get a trial, you need evidence, and in order to get evidence, you need a trial. And often the only way to break that cycle is being someone on the ground floor, not being a big corporate, big multinational, but being someone on the ground floor that just wants to solve a problem for somebody, that goes in and listens and spends time, really understands it, builds a relationship that then de-risks that trial for the people that can implement it. So do I think there's a role for startups? Absolutely.
So Abdullah, I mean, you've actually delivered an IT solution into the NHS already with Discharge Summary. Can you talk a bit about your experience of that? How did that come about? How easy is it for a startup to kind of get innovation going within the NHS?
So this is, Helen's talking about our first product, which was called dischargesummary.co.uk. And essentially it's a very simple website which was designed for junior doctors to use in order to produce standardized discharge summaries. Now, a discharge summary is a document which is produced every time somebody leaves the hospital. So the idea is you visited secondary care, being the hospital, you're now going back to primary care, being your GP, and your GP wants to understand what happened to you, why did you stay in hospital, what test did they do, what did the tests find, and what did they treat you with, what was the diagnosis, and now you're back in my care as your GP in the society and community. What should I keep on doing? Should I keep on prescribing this drug? Am I meant to check your blood tests again in a few weeks? So discharge summaries, as James was saying, is the idea of finding what is the pain point, and from a doctor's perspective in the hospital, from the doctor's perspective in the GP practice, and for the juniors themselves, it was a pain point for everybody, because when somebody is leaving the hospital with something very complicated, say like a heart attack, the junior doctor is rushed off their feet, understaffed in the department, and wants to just knock out this document as quick as they can so they can go back to seeing patients. And they have described a really complicated heart attack, 2-week admission in 4 lines. And that's got sent to the GP. Now the GP on their end is thinking, what the hell happened? There was a heart attack, what drug should I continue? I'm really confused here. And for the junior doctor themselves, they're just getting swamped in all this admin that we have to do. And I think if you ask any of the doctors here or medical students, this is a large part of our career, the early stages of doing a lot of this kind of work, a lot of this admin work. So discharge summary was simply a template to help facilitate the production of these discharge summaries. Now, it's completely for free, and it's still for free. So we rolled it out in Leeds Teaching Hospital, which is the biggest teaching hospital in Europe. It's now in University of Lewisham Hospital in London, as well as Queen Elizabeth Hospital in Woolwich, and it's being rolled out in further hospitals in Bristol as well as in London. And it's something we still do. So despite having the success with Medical Chain and going off in a direction with Medical Chain, we're still completely supporting discharge summary and wanting it to succeed. I think coming back to the points that were raised earlier as well, it has to be a bottom-up approach. So the reason discharge summary worked is because I didn't go to the NHS director, I didn't go to the manager of the department. I went to my colleagues and I said, look, this is a website, we can use this to help us. And it's any website, it's like using a calculator. It's up to you if you want to use it and then plug in that information into what you're working on. So all the juniors started using it. The consultants noticed the productivity of the work went up. We were finishing things faster. It was more accurate. The department was making more money because there's a thing in the NHS called coding. So you have to demonstrate that these activities took place, and now we're going to get paid for those activities. Then the consultants took it on board. Then they took it to the managers, and then it started spreading to other consultants in the country. So I think for a startup, it's our maneuverability, it's our flexibility, and it's the idea that we can get in those nooks and crannies because we're down on the floor, on the shop floor, rather than a large organisation where if you're talking to the decision maker, you'll take years to filter all the way through, and it turns out you were talking to the wrong decision maker the whole time.
I'm so glad you said that, because one of the reasons I got so interested in blockchain was after years of kind of people talking about healthcare innovation in policy seminars and sort of grand reports. I just thought that actually when I started understanding this technology, it would be able to come from the bottom up, and that would be the way you would sort of insert innovation into the NHS kind of internally, rather than trying to somehow impose an innovation framework from a kind of theoretical, intellectual, political point of view, which is just so slow moving and really, really hard to make any changes. It takes years and years and years to even get people talking and understanding something. So yeah, I hope you succeed. Coming to Navin, I mean, we just talked already a little bit about, that's a kind of data sharing problem in a way. What is it that's so difficult about the NHS when it comes to sharing, outcomes data and medical data, and how are the projects you're working on helping to change that?
I think Pradeep, you said some great stuff there. The technology is only a teeny part of it. So the big thing of sharing and making systems work is to sort out the processes that people use and actually getting people on board. So there's more people and processes, and the last bit is IT. But even within IT, so you keep hearing blockchain is going to solve interoperability. And that's rubbish. So interoperability works at many different levels. Is there a willingness to share? Do I want to give you stuff? Cool. And that's a much more personal aspect, and you've got to set up a contract for that. So that, not really, that you have to have that discussion first. Then there's the bit of actually finding the data and sending it as a packet. That maybe we will do. But actually that kind of happens at the minute, and I can interoperate with you by sending you an email. The problem with it is if I send you a PDF file with 100 pages, no one's going to read it. So the next step is semantic interoperability, which I did a lot of my early work on, which means can you code all the data? And can I send it? So I've got it coded nicely as age, date of birth, height, and I send it over to your system, and it instantly understands everything and puts it into the right fields so that no one has to type it in. When we get to that level of semantic interoperability, that's when we're going to actually get proper sharing. And that's when you can start thinking about machine learning, all that other stuff. Because, again, that's another side point. Everything right now is full of hype. And when you get to machine learning, there's this expectation that it'll solve everything. And most of the time, it's using flawed notes that it can't properly understand and it doesn't get the context of. So we've got to take that out of the equation. So the things I'm working on right now are, can you code this stuff properly? It doesn't sound very sexy, to be honest, but the projects we're working on right now are, can we take healthcare sensor data, send it securely over this ledger for free to a hospital, and can they interpret it and get some analysis out of it without any problems? And we're getting out there. The wider thing we're trying to do, we're getting a lot more headway in Scandinavia, who are a lot more progressive thinking. So within Oslo, in April, we've got a 300-person conference trying to build these systems. And that is mainly Oslo, Finland, Estonia, Denmark, Sweden, and Iceland. And I'm trying to drag the UK up there because we have to be dragged. So yeah, it's when it comes down to it, the NHS is a bit of a monolith. It's quite hard to get through, but I think it's got very strong people in there and people who care. Will the blockchain save the NHS? Hell no, because what the NHS needs is more funding and less expectation.
I guess we can debate also where that funding might come from, because I think that the way the funding is organised is an interesting point, and then maybe actually blockchain and tokens could also address that and maybe make the silos between public and private a bit less stark. But I don't want to get too much into how health systems are funded without kind of starting another whole 3-hour debate. So what I'm going to do is actually turn it over to the audience now, and I'd love to hear your questions to the panel. And at the end, I'm also going to ask them to sum up a little bit with what their kind of key messages for policymakers, if they could talk to people in the NHS, what they would like to tell them about blockchain. And also if they have any view on which type of blockchain is most suitable for healthcare reform. But let's turn it over to you all, because you're all waiting here to ask your questions. I've got Paul at the back, I think.
Yeah, hi there. My name's Paul. I work for NHS Improvement, which is economic regulator for the NHS. We talked a lot about the role of kind of patients as consumers, which is always a bit difficult in the NHS, but it's a really key part of it. But what about the relationship between providers and providers, payment between providers? Because, like, I'll give you an example. Helen brought the point up earlier about maternity. We've got a payment model in the NHS for maternity, for example, where you have a lead provider and they cover the full care for someone going through maternity, and every other piece of care they gets paid back to that lead provider. And it's a hugely complicated, bureaucratic kind of process, and there's huge amounts of system working as well. So the kind of payment between providers, a hospital and another hospital, a hospital and a GP, is there kind of experience from America or another where that's kind of where this can actually unlock some of that?
I think that's probably a good question for you, Pradeep.
Yeah, I can actually give you a very specific example. So you're talking about delegated payment authority. You're giving a third-party payment, someone a centralized payment model to then distribute to all the other care providers, right? So we call it delegated payment or third-party payment model. And there are clear use cases of enforcing the proper distribution of funds from the lead provider to all the secondary providers, both from a timeliness and from a measuring the right processes were followed. Now you could do that with a centralized system. There's no reason why you couldn't do it with a centralized system. The problem is if those stakeholders change. If you end up with referring the case to someone who's not already integrated with your delivery process, then you have a problem. So the exciting part of a chain that they can subscribe to for a single case and subscribe out of and carry the payment with them is very attractive. And then there's the immutability of the chain, which lets you track afterwards. One of the biggest problems with third-party payment is this. I'm giving you money, you distribute it, then I have to come back and audit to make sure it was distributed correctly, 90 days, 6 months later. So I had to recreate history using your system and all the other systems which don't talk to each other, and I have to somehow prove that all the things that I expected to happen happened in the right sequence and for the right reason. That recreation of history is really, really hard and almost always never accurate. So you end up basically doing a sampling, 5%, 3% statistical analysis. So with the chain, if you were to actually implement a good use case where you are tracking all the delegation events from me to you to the secondary provider, the tertiary provider, it becomes a very attractive use case, as long as you make sure that it doesn't turn into a integration mess, where everybody has to be pre-integrated into your chain. Then you're just building a big, huge HIE, Health Information Exchange. And those things have not worked, right? So don't reproduce the mistakes. The $30 billion of learning we already did in the Obama administration, building all these systems that nobody uses. So I guess in short, the answer is delegated payment authority and delegated payment model is growing around the world. It's a great use case of blockchain, not an easy one, but it does represent the ability to have a dynamic network of providers to come together for a single episode or a single patient and then never come together again if they don't want to, and still have full auditability. That's what you could do with a properly used blockchain, properly implemented blockchain.
So yeah, I mean, that comes back to the key point about this kind of audit trail, if you like, this sort of bank statement of all the transactions, which is one of the key properties of blockchain, that we can see what's happened in more or less real time, and we know we can trust each other in the system.
Thank you. It's just to add on, so there's a Russian company called Robomed, which are trying to establish these kind of smart contracts. And the idea of a smart contract using blockchain is that we have agreed that if so-and-so activity happens, so-and-so other activity will happen. So if I treat the patient, I will get the money. And the difficulty of implementing such a project, I think, in healthcare is you're taking away the autonomy of the clinician here, and you're taking away the autonomy of the patient. So the way this Russian company were doing it, I have no idea if they're successful now, is the patient has come and established a smart contract saying, I think I'm coming with a chest infection. And if the doctor doesn't treat the patient as a chest infection, the funds will not be given. And it turns out the doctor may have actually detected lung cancer, and it wasn't a chest infection. So it's something that really needs to be ironed out when you're trying to do these smart contracts between providers and suppliers, because they might come to different conclusions and you've tied them into a contract where the funds won't be released.
I think that probably strikes fear into the heart of policymakers if they hear something like that.
There's a deeper issue with that as well, because I had a chat with those founders, and their unique selling point was that there was a Harvard professor who had written these smart contracts, yet they wanted to implement them in Bangladesh and India and Pakistan. And they were going to use the same algorithm made for a Western population in Boston with like a village in Bangladesh. And that just doesn't work. And that's, you've got to have enough variability and scope within that.
I think there was a question at the back there.
Hi, thanks very much. So it's a question to Pradeep.
Can you say if you're from a particular company or where you're from?
Absolutely. So I'm a general surgeon, just training. So a question for you, just in terms of how this model might work in terms of supply and demand. So if I'm a patient and I want a hernia operation and it's all about value-based healthcare, how do I choose what metrics will I see for my surgeon? What will help me do it? How will you make sure those metrics are what the surgeon wants to show you? And the second question is, as a surgeon, if you're going to base my value on patient-reported outcomes, how much information will I know about the patient? Will I know what they've liked, their previous complaints? You know, we often talk about the size of the patient notes depicting how long the healthcare consultation is going to take. How much information will you share that way?
These are great questions. But let me take the first one first. So as far as how will the physician get paid? I believe that was your question. Or how would I choose the physician, rather? So there are two parts to this. First is the physician even qualified, right? So there's a whole use case around physician credentialing or qualification. So we use the term credentialing in the US. I think you use qualifications or certification here, same idea. And in that regard, the question is who's certifying the clinician's ability to treat a certain event, episode, chronic or episodic, doesn't really matter. So there's clearly we have heard of use cases already being talked about as far as Middle East on the clinician credentialing or qualification assessment done by peers on the chain. So they are essentially able to certify or decertify a physician's ability. They've kept up, and there are certain, in the US we have 3-step model. Are you who you say you are? Do you have the up-to-date qualifications? Have you kept up to date with your continuing education? And do you have any sanctions against you in some database for malpractice or abuse? Once you get through those 3, you're done. You have a credential and you can now treat patients, right? But there's a fourth element, how good a physician you are, which is very controversial, but it's an important element of how do I as a patient choose a physician. I can go to healthgrades.com, hopefully you are there, and look for some random rating, and I probably can't trust it because it could be totally plagiarized or completely nonsense. So the idea of a chain becomes, if we can continuously measure performance of a physician, it's not the absolute measure of the physician, but rather a relative measure against other physicians of similar ilk. And we see a continuous imbalance between recovery time, continuous imbalance between cost of prescription or the net result. Then you aggregate enough data to say, okay, this physician has a high performing score or a low performing score. And then you can tell them where they are low performing so they can improve. If you publish that data on the chain, now the patient has some metrics, some empirical evidence-based selection mechanism. Right? Otherwise, how do you choose? You choose based on availability first. Who will see you? Right? That's the number one criteria of physician selection. Who is near me and who's available? Most patients do not choose based on any other evidence data. Where do they get it? Nowhere. You can go to a third-party site like WebMD, where I used to work, or Health Grades, and it's highly suspect data. There is no one proving this data is right. So that's where the chain becomes very interesting. I, as a patient, for the very first time, could envision an evidence-based measure. That may not be the definitive reason I choose you, but it is a factor in my selection. Among other factors like, do you speak my language? Are you the gender I'm comfortable with? Are you available on Tuesday at 3 p.m.? And so on, the real practical reasons, right? So that's how the chain helps in being a bidirectional transparency, if you will. But it is going to be a fairly interesting use case that will require some real thought. But we are seeing a lot of discussion around physician credentialing and quality measures published on the chain for the use of the patient, right? So that's one. If you have a follow-on, please go ahead.
No, it was just the second part of the question. How much can I see about the patient? Can I choose my patient? Because I'll take the easy ones. I won't do the hard ones.
I think Abdullah might want to comment on the patient info side as well, maybe. But
yeah. Well, I mean, look, the human behavior around how do you optimize your time and who do you see, we're not going to alter that with just the chain, right? So if you have the ability to choose your patients, what are the criteria you're going to use? So here, the reverse is true. If I can give you the ability to fulfill the blank spots in your schedule where you have low time available but not enough patients, we want to do a demand-supply balance rather than a selective process. So, for example, we talked to about 1,000 physicians in a particular state as a sample recently, and we talked to them about what do they care about the most. And one of the things they care about is an equalized revenue model where they have relatively equal amount of utilization of their time. So on Tuesdays and Thursdays, if they have a high availability on their schedule, they want to fill that. So one of the use cases in chain that is very interesting right now is that patient can publish a need on the chain, not so much in the sense that I think I have lung cancer, but rather I need to see a physician, either a GP or a specialist, because I have a referral in my hand. And now I need to know who is available at 3 p.m., because that's when I can get off work, rather than wait for a physician to tell me when they can see me, then I take off from work. So if we can actually do a demand supply where the patient's needs are on the chain, and your wallet has the ability to interpret that need and say, well, wait, I have the credentialing qualification to treat this patient. I will accept him on a Tuesday at 3 p.m. because I do happen to have. So sort of like in reverse model, rather than me chasing physicians, the physicians can tell me when they are, if they can see me when I am convenient. That's a really big issue, because when you look at subsidized populations like Medicaid or Medicare, physicians don't want to see them. They don't pay as well. You know, we pay you 70% of the rack rate, so why would you see me as a Medicaid patient when you can see Abdullah who will pay you 100% of the rate? So, but the reason you will see me is because I can come to you when you have no other patient to see. So this is a demand-supply balancing where we are trying to solve this issue of access to care. It's economics. It's nothing more than it's economically beneficial to you, and it gets me the care I need.
Sorry, in terms of the complexity of the case, then can I dictate I want half an hour rather than 15 minutes? How much data are you going to share with me, and how much ability can I say no to? And then does it go on an open market, and therefore do you get people bidding at the very last stage because they just want to see the patient and get paid?
Yeah. So it depends upon your compensation model, right? If you are a fully capitated physician where you're paid a salary, you're not going to pick and choose. You're simply going to make sure that you're well utilized and you can do your job. If you are a physician paid for services, you clearly want to maximize your revenue or value of your time. In the end, it very much is driven by your payment model. That is not a, it really does change based on whether you are a fee-for-service physician in a value-based contract or in a fully subsidized employment contract. So the answer would vary. I don't think that we could say physician behavior is constant regardless of payment model. It actually is very much influenced by payment models.
I think that raises two really kind of fascinating points. I mean, one is about, if we're talking about how do we save the NHS, one thing is patients are unempowered, and why does that matter? It matters because if patients don't have much agency, it's hard to drive up quality. So in your system, you're talking about a system where people have a bit more ability to choose, but in the NHS, it's usually quite hard for patients to have a lot of choice. And so actually, if you could facilitate that matching process and you could improve the ability to choose, it could potentially help drive up quality. I mean, at the moment, the NHS has choose and book, where you can often not really choose or book, and therefore, the idea of having a sort of quality improvement mechanism is really failing, because the IT system doesn't allow you to book, and then a lot of the clinics are not in the system, so you can't actually choose. So, both of the factors of choose and book are essentially, not executed. And then also, I guess, from the patient point of view, having more information, because at the moment it's very hard to get information, certainly in the NHS, about doctors. Only the most informed patients will really go and look up and find quality information about doctors, or, maybe if they're having an operation, they'll look at, success rates of surgery, but it's very, very rare, I think, that patients do a lot of research into doctors. So, can blockchain help us improve that? I mean, I'd love to know Abdullah's view on how all this information is going to drive up quality.
Yeah, I don't think I have a direct answer for you, but I think going back to what you said earlier, in the sense that you can get given loads of information, but it's what you do with that information that actually counts. So, I think from the way we've been trained as doctors here in the UK, nobody goes out of their way to hurt themselves or be a bad patient, or they don't want to suffer themselves. I think it's quite the opposite, in the sense that it's the lack of information the patients have, or more importantly, the lack of information that the patient retains. So you might be an absolutely fantastic surgeon, and you've dotted all the I's, crossed all the T's, went through all the potential complications, explained to them that they needed to stop smoking, lose weight, but you have to put yourself in the patient's shoes. This is a person who's anxious about surgery. They've never done this before in their life. Half the terms you're using, they've never heard of it in their life before. And what we're trying to do in terms of empowering patients is so that if they can access their records in a view-only format, they can go home and review your clinical notes that you said, or review the clinical letters you went through. So the idea is, it's not exactly answering your question in the sense that as a surgeon, I want to see my patient's records. By all means, if they share the records with you, you can see their records, and you can decline them before they've even gone through the door. You can say, I wasn't going to take anybody with a BMI of over 40. But I think the other way of approaching this is actually trying to empower patients and put the responsibility back in their hands. I could be an amazing surgeon, but if you continue to damage your body in X, Y, or Z way, the whole surgery is a complete waste of time. And I think when patients are empowered with that literature and they're able to review it and in their own time go back and understand it more and digest it more, that will produce better results from a surgical perspective or any other clinician's practice.
Navin, comments on kind of how we use data, because obviously a database is only as good as what you put into it. So, you know, if blockchain is just a sort of glorified database, is it going to be good if we don't have the right information or the way to, I guess, assess the information and package up that information usefully?
So I think you kind of answered that. Rubbish in, rubbish out. I think I wanted to touch on what you were saying. I think we've kind of skirted around the issue. I think you're talking about the situation where the patient gets a choice and decides, I want to see that doctor at that time, and maybe at a certain price. But there's the converse, where does the doctor get to say, this patient's going to be in a wheelchair, it'll take me 40 minutes to see them, and actually economically that's not viable for me. So do they get to block the patient? Say in exactly the same way as like tertiary providers related to the NHS may cherry pick only the very simple cases, and per patient they get paid a higher tariff because you're not dealing with the complex patients. Can doctors now do that? And that's a very important philosophical question. It brings across like your Hippocratic oath versus economics. And
are you talking on the basis of whether it's financially beneficial to them or whether it's medically worth the effort? Because that's a different... I mean, they're interrelated, but...
Yes, from how I see that question being asked, I think it's more in terms of financial gain. If I can see 10 patients during my clinic rather than 5, that's more beneficial to me. And there's also a thing of medical legal risk. So if I tend to only take low-risk patients, and this is what we're talking about, I can tell how good they are. But actually, if your system's not sophisticated enough to risk stratify the patients before their treatment, then every surgeon's going to be like, well, I'm going to take completely fit and well under 40-year-olds who I can treat in 5 minutes. There's also a different thing about that. And I always think about eBay sniping, where you think, okay, if it's supply and demand, you do get that to an extent where you have unfilled capacity. But are we going to now move towards a system which is like lastminute.com, where you say, okay, I've got a free slot in half an hour, anyone who can get here 90% off? And are we going to encourage that kind of dynamic within the healthcare system?
That would seem quite antithetical to most, I guess, British people's view of what the NHS is about, but it's definitely one way it could go.
So this model of care, accountable care organizations exist in the US now for about 3-4 years. And this exact debate, I think, happened in the political realm in the US as well. Will the physicians cherry pick? Will it result in picking only the most, highest quality, highest value patients? The reality is that all the data that we are seeing after 3.5 years of this being in practice is no, we're not seeing that. We're not seeing any evidence of. Now, there are certainly optimization happening, we see that. But the thing is that on the chain, you can also very quickly see patterns. You can start to see that there is a cherry picking going on. When I look at the vast majority of the patients from this hip surgeon, they're always under 40, but the demand in that area is not centralized to the young people. So it's what we are seeing is there is actually the issue is clearly there, but that happens even today without the chain.
I'm saying everything's down to information asymmetry, and we've talked about that before, where you said the patient doesn't have enough metrics about the doctor. Mm-hmm. What we see right now with the doctors accepting patients for a referral, they usually have no information. So they accept it and then assess afterwards. If we now reach a system where the doctors can actually see much more and assess and pre-screen them, are we going to end up in a differently incentivized system to the NHS, but in a different system, will you end up people screening the less profitable patients out of their clinic?
Or they are equally profitable because you actually pay based on effort and results. So in other words, if you can screen out a patient saying that's going to be a complex patient, then I can incentivize you to see that patient as easily by saying, okay, you are dealing with a multi-chronic, paraplegic in a wheelchair who has a history of hospital admissions and a readmission rate that's every 30 days and has a history of not filling a prescription, so I can do something, right? I can incentivize the patient to do something better about their care, and I can incentivize you to treat them better. I can assign a case manager to them. What would I do as an insurer? I mean, this happens all the time. You get a multi-chronic patient that single-handedly costs you $2 million a year because they end up in the hospital every 28 days on average, and every hospital admission costs me $22,000. What am I going to do in that case? I'm going to do the same thing. I'm going to treat this patient as a special care case. I'm going to give you a lot of money as a physician to treat this patient, far less than $2 million, but far more than your normal rate, so that you don't get him back in the hospital, right? So we have to create this win-win model. Care coordination and care management for complex and multi-chronic or multi-episodic scenarios require special payment. We do that today. We just do it in a very poor way. We do it after the fact. 2 years later, somebody like me in a CIO role looks at it and goes, here are my top 7% users. Average cost of care for this family is over $150,000 a year. I gotta do something. I assign a case manager, and I start assigning a patient-centered medical home, and I start taking you, Naveen, and think, would you take care of these people 100 grand a year? And if you still can't do that, I'll give you another 50 on top, but please bring him down from 2 million, right? So, I mean, look, everybody can see the same scenario. You can see the patient as a problem. I, as a payer, can see the patient as a problem. And the patient can see they're a problem. And in that case, we can coordinate their care better. So all I'm trying to say is that accountable care doesn't work where the physician gets penalized. That model breaks down like that. But when you can use accountable care to give the patient, the physician, the tools and the right reimbursement, then we start to bend the cost curve. Otherwise, it's somebody loses, somebody wins, and there's nobody winning. Really, the patient.
I think the question is that split of winning versus not versus your Hippocratic oath of having to do that, and that's the crux of what we're talking about. Is can we balance it out? Can we incentivize you? But what's your role and what have you sworn to do? And that's where it becomes a bit more tricky. And there's no easy answer. I know that.
Yeah, no, there isn't. But again, I would say that maybe data shows that most physicians are much more bound to their Hippocratic oath than to maximizing the revenue. But at the same time, they have a business to run. And if you penalize them for taking care of the hard patients, they will eventually stop doing it. So it's our job as a program administrator to incentivize you, not to penalize you for patients, multi-chronicity.
Let's go to one or two more questions before we have a drink. Amit.
Hi, Amit Patel, New Ventures Bupa. Really interesting debate, and clearly all of the exponential technologies, whether it's blockchain, machine learning, AI, will have a dramatic effect on customer experience, productivity, value, outcome, all of that kind of stuff. I guess one of the points for me is where do you see it going? Do you see ecosystem reinvention creating new digital economies? Because some of these points around how doctors get incentivized, how they might behave, how customers might behave, how other participants of the ecosystem derive value, that could all potentially change in a new world, and we don't know how that could work. Versus to get adoption in somewhere like the NHS, you've got to solve a real problem, which is a problem which may have a 3-year time frame because the decision maker wants to create success. It's got monetary value attached to it, but it's not that reinvention because that's something different. And when I go back to that very practical thing, I think about WannaCry, integrating into legacy systems, all of these good things that are a hindrance to integrating kind of new technologies into existing, right? So I just wanted to understand where you see all of this playing out, because clearly you've got to start somewhere. But if you start where you naturally have to start, I think you don't have the opportunity to step change.
Yeah, I mean, that was actually a point that Stuart wanted to make as well, and he's not here, but he talked to me a bit in an interview recently about, some simple things you can do in the NHS. So, if it's HR, you're constantly having to check up on temporary doctors and fill out a lot of paperwork and compliance documentation, and if you could standardize that and have people be able to share those records using a distributed ledger system, you wouldn't have to waste all this time, and then the doctor moves on 3 months later and you've got to start all over again. So that's a sort of very basic kind of practical but really important cost saving measure, but it's not sort of sexy in inverted commas and exciting. It's not a transformational, let's turn the NHS into some very new innovative way of doing healthcare.
I mean, it's a really difficult question to answer, because you're saying, what's going to happen in the next 10 years? Where do you see that going? I think the reason we used blockchain, for example, in medical chain when we were doing this, and many people have asked us, why do you even use cryptocurrency in medical chain, is really the idea that you are trying to bet on this winning horse. You can see that blockchain does seem to be something which is going to be the next internet, if you will, to coin a phrase. And if you're going to build anything, you want it to be future-proof. Now, in our medical chain platform, it's getting a little bit technical for some people, but we use Hyperledger fabric that we're building on. Now, lots of people don't like that. There's quite like a religious following of Ethereum or other ways of building things. But the idea is that as long as you are able to pivot to the next idea or the next successful technology which comes along, I think that's going to be the key success here. I think the reason why health institutions such as the NHS or others worldwide become so ingrained in their way of doing things, and I think there's another point coming back to your very first question of why as a doctor did you get involved in the NHS? Because at some points in my training it was just so painful to be told by someone, well, that's just the way it is. And I think we've all experienced that. You'll ask for annual leave 2 years in advance for your wedding, and they'll be like, whoa, I don't know, that's just the way it is. And I think to get away from that, you have to always be quite dynamic, and you have to always change to the next best solution that you can find. And I think for the problems such as with staff moving around, repeating their documentation in HR, sure, you can put it on a blockchain, you can prove all their accreditations or qualifications. With medications, you can prove where the medication started from, and you can use blockchain to show where the origins of that came from and how it's moved through the system. There's lots of ways of employing this, but you shouldn't just employ it for the sake of employing it. And it's the same with cryptocurrencies. A lot of people are just generating a token for the sake of generating a token. And they're doing it on the guise of, because now you can do this wonderful thing, or you can do this wonderful thing. And well, you could do that anyway without the token. You don't need to use that. And I think those are the hardest points for me is, how do you sort out who's actually genuine? How do you sort out someone who's actually got this idea, thought it through, and does actually want to carry that idea through? So, for example, with our platform in the pilot we've got coming in the summer, the doctors we're working with in southwest London, they've got 30,000 patients, and they're going to accept cryptocurrency as a payment for their private patients. So that'll be med tokens, Ethereum, Bitcoin. It might completely fail, but that's the whole point of a pilot. I'd rather it fails there and then, and we iron out what the problems are, and people could say, well, I told you that ages ago. Okay, but we have to test it, stress test the system, adjust things, and then go for the next pilot and the next one. And I think that's the only way we can do it, and it's this attitude of a community. If you want it to succeed, it'll succeed. If you just step out and point and say, that's what's wrong with it, that's why it's not going to work, okay, well, it's never going to work. If you have a solution, then tell me and we can work on it together.
I'd love to sort of conclude around that point with final kind of conclusions from the panel, because I think that's the key thing. That's why I got into, I guess, policy work, and it's why I got interested in blockchain is I don't want it to be, that's just the way it is. And that's why I really enjoy working with all the innovators that I've met over the last 4 years and trying to bring them together with people in the decision-making process to try and get that going. So, I think I might have to get that stamped on my wall somewhere, but that's not just the way it is. I'd just love to go along the panel, maybe starting with James, and come down and just ask you to give a few final thoughts on what you've heard and any message for the Secretary of State for Health. We are on camera, so be wise in your statements.
Yeah, no, so for me, the discussion's been fascinating. I think there's been a lot about almost the philosophy of blockchain and where it sits. There's been a little bit about the adoption of it and how we get it in on the ground floor. For me, I think it'd be really interesting now to hear the question being, can blockchain save the NHS? I think from that ground floor implementation perspective, I think it'd be really interesting to hear from a panel of NHS Trust CIOs, CCIOs, finance directors and IT managers to see if they've even heard of blockchain, to see if those systems are even close to being ready for this, to wonder, what does a business model need to look like for blockchain in order to get adopted? Now, the way Abdullah's going about it, going to GPs, GP practices, and then using cryptocurrency in their private practice. Yes, that's not fundamental at big NHS hospital, but it's a way in. It's an innovative way of approaching healthcare with a new technology and starting to bring it in, and I think that's fascinating. I think do this again with some CIOs, CCIOs.
I love it when people give me an idea for a follow-up event. That's very helpful. Thank you. You can come again.
I think I've spoken a lot, so I don't think there's much more I need to say. But
never enough for me, never enough.
So, essentially, don't believe the hype yet, because I think everything is still alpha phase. For it to be enterprise ready is going to be at least a year, 2. But if you don't start now, you never do anything.
Pradeep.
I want to come back to your question about integration. Look, data has to flow between systems, legacy and new. Always been a challenge. When the web came out, it was always the question of how will we ever free the data from the mainframe. And the reason we did it is because it made economic sense, right? And early adopters proved the economic value, and the adopters, then the rest of the industry jumped on. Blockchain is no different. It's only going to be driven by economic value. Can we move data? There are 1,000 ways to move data, from something very crude like a file transfer to more real-time to nodes on the chain. Doesn't really matter. The technology exists. The question is economic value exists or not. So the data, as a data holder, as a CIO at Blue Cross, I would not integrate with your system if it doesn't have clear ROI, clear empowerment of some stakeholder, and there's no business value I can defend to my board. It's very simple. So it's not the technical issue of data integration. It's always a question of what drives me to do it. And if blockchain use cases are compelling, you will get the data. If a use case is ethereal and cannot be touched and cannot be proven, I'm not going to spend my precious IT dollars on connecting to your system. It's all going to boil down to the ROI, the return on investment.
Thank you. So I think I've also spoken a lot. So I don't have a lot to add. I think if you switch the question so that some people are quite scared of the word blockchain or don't feel they're an expert in it. So the first thing is there's no such thing as a blockchain expert. Okay, this is like a book, and I'm probably on page 10 and you're still on page 1. But there's another 3,000 pages to go, and everybody's learning at the same rate. And I gave a presentation at Imperial on Monday, and there was a gentleman there called Ian Stewart, who's one of their researchers, fascinating man, and he's doing research on it, and he's there going crazy with the chalkboard, explaining blockchain to us, and he's lost me, and I'm meant to be in charge of this company. So there's no such thing as a blockchain expert, is the first thing to say. There's lots of people that are just discovering it, and if you want to simplify the question, can blockchain save the NHS? I mean, just ask yourself the question, can the internet save the NHS? Because that's what the question essentially is. You've got this fantastic tool that's got lots of versatility. Can it save the NHS? Well, I think so, yes. But in its current format, no. Within a year or two, absolutely not. But it's down to us, sat up here and other companies that we interact with, of how are we going to use this tool? What are the kind of innovative ways can we do that? And I think we've really demonstrated that, because it piqued all of our interest when we heard about Bitcoin or Ethereum. That's how I heard about blockchain, and that was just about making money. But now we've come a long way from that, and now we're actually trying to find ways to solve problems using blockchain. And I'm sure if it's not us, but the generation after us, they'll have an even better solution of how to utilize that technology.
I completely support what you said about education. I mean, obviously that's what Unblocked is all about, and that's where I started from, is going to a lot of conferences where people talked about Bitcoin and blockchain, and not coming from a technical background, but coming from a background where I thought I was quite good at understanding kind of complicated ideas and explaining them to other people, and just feeling that really often the talk is going way over the head of just the average professional person. And I think when it comes to policymakers, they're keen to learn about blockchain. They're still kind of starting out on that journey of understanding how it might impact on what they do and on the public sector. And a few sort of points that I've made in the past is obviously we all have self-interest. So what's in self-interest of policymakers? One is to cut the costs of what they do. And I think blockchain can do that up to a point. Another is trying to join up different systems. The welfare state is not just the NHS, it's a whole bunch of other interrelated systems and things that we offer to the citizen. And actually, at the moment, they're all separate. You've got the NHS, you've got unemployment benefits, you've got education, everything's very separate, and these things don't link. And actually, when we were talking before about certain people cost more than others, when it comes to the welfare system, you've got certain citizens who may have more need for help, and actually we don't join those up. We don't say that the child that's from a family that's struggling and that hasn't learned to read by the time it goes to school and that has more healthcare problems and maybe won't go to the dentist, that's actually all one person, but the system treats them as these separate individuals, and it doesn't link up all the services that are being offered to that person. So if blockchain could find a way to create an ID where we can see what's going on with those kind of individuals and target support to those kind of people, I think that could be enormously beneficial. And I guess the third bigger point is, we're not just talking about the NHS as something that costs society, we're also talking about our healthcare, which is something that can potentially bring benefits. So let's bring innovative companies to the UK to do these kind of new business models and improve what we do and make Britain a place where blockchain companies want to be. And I think that's something that the government is starting to look at and should do a bit more of. And I hope I'm going to try and help them do that a little bit by giving some access to some of the people that we've spoken to today who are all building these projects. So I'd like to just finish really by thanking everyone for being here. Thanks Stuart, who tried to come and couldn't, but sent some fantastic comments to me beforehand, which I've tried to incorporate. And thank all of you for making it, and I hope you'll stay with us. And if you've got further questions, come and have a drink with our speakers, and just enjoy the drinks and warm up a bit now that the doors are closed. Hopefully we'll warm up a wee bit. Our winter crisis is about to end, hopefully, by early next week. So let's all join together and thank the speakers for being here.
Thank you very much.